Thank you for the opportunity to present today. I'm going to be talking today about cystic fibrosis liver disease and endocrine considerations. Just an outline, I'm going to talk about cystic fibrosis-related liver disease, and overview, epidemiology, diagnosis, pathophysiology, and treatment, and then endocrine considerations, and talking about nutritional deficiencies, cystic fibrosis-related diabetes, and bone disease. And I think, just in general, as an endocrinologist, we really don't think about the liver as much as like the GI folks talk about that, but it's really an important endocrine organ. And I feel like it's very important this is a very important topic and one that we need to learn more about. So what is CFLD? It's really a broad term for a different collection of pathologies that includes mild transaminitis, hepatic steatosis, focal biliary cirrhosis, and then gallbladder disease like cholecystitis and cholelithiasis. And you can see here pictured, there's different histological findings that are all in the bucket of CFLD. So in this top panel here, you can see you can see some portal fibrosis that's circled here, and then some mucus plugging in the brown here. In panel B, that's diffuse nodular pattern, and see that the purple here is some hepatic fibrosis in the blue, and then steatosis circled here, and then panel D is just diffuse steatosis. So all of these fall under the bucket of CFLD. So why should we care about CFLD? It's actually the third leading cause of death in patients with CF, and it contributes to really clinical deterioration, including decline in lung function, increased need for nutritional support, need for higher risk of hospitalization for respiratory and non-respiratory indications. About 30% of patients will actually develop some form of liver abnormalities, and 5 to 10% will progress to cirrhosis, and then 2 to 3% will develop portal hypertension. And really, this is actually, CFLD really is classically a childhood disease, with most cases presenting in the first 2 decades of life, and the median age of diagnosis at 10 years of age. And the majority of cases of CFLD are diagnosed by the age of 20, although with increased life expectancy, we are seeing adults who are developing liver disease. So the prevalence of CFLD is really dependent on the definition used. Asymptomatic liver enzyme is very common, and 20 to 30% of patients will actually have sustained elevated liver enzymes in the first 2 decades of life. And then about 20% of patients will have actually abnormal liver ultrasound findings. And if you look at autopsy studies, ranging from 10 to 50% will have some evidence of liver disease in autopsy. But despite the frequency of these lab abnormalities, only 10% of patients with CF will go on to develop cirrhosis, and only 2 to 3% severe CFLD with portal hypertension. So what is the cause of and the pathogenesis of CFLD? The classical thought is that it's due to the underlying mutation in CFTR, which basically is in the bile duct epithelium, and that's thought to lead to biliary stasis and mucus plugging in the bile duct. That will cause periportal inflammation, and in some patients it will lead to fibrosis, with a subset of those then developing cirrhosis, and an even small percent of those developing portal hypertension. And in terms of risk factors, what causes some patients to progress to severe liver disease is not known. We do know that patients with severe CFTR variants and also pancreatic insufficiency are much more likely to develop cystic fibrosis-related liver disease, but most patients who have severe CFTR mutations actually don't develop liver disease. And then there have been genome-wide association studies that have examined genetic modifiers of risk factors to develop CFLD, and one of the highest hits is in the SERP1A Z allele, which is a variant for alpha-1 antitrypsin. So in terms of the diagnostic criteria, there actually isn't a uniformly accepted set of diagnosis. In 2011, Debray proposed a very broad definition that required two of the following: either abnormal physical exam, like a hepatosplenomegaly, or sustained elevated liver enzymes for a year, or ultrasound abnormalities. And then Narkowitz in 2013 proposed a more narrow definition with CFLD with evidence of cirrhosis and portal hypertension, and then more a general diagnosis with the, liver involvement without fibrosis, so with mild elevations of ALT/ST, abnormal ultrasound, or abnormal histology on biopsy. So in terms of screening, annual screening for CFLD is recommended for children with CF, and because it's a pediatric phenomenon, the role of screening adults without any signs of or previous history of liver disease isn't known. And it's unclear, but things that have been used for screening are liver enzymes, but liver enzymes alone have very low specificity for prediction and development of severe liver disease. There have been additional markers that have been used, such as a lower falling platelet count, that can be helpful, and then a few sort of scoring systems that take into account liver enzyme, platelets, the the fibrosis 4 score can increase the sensitivity and specificity of actually predicting progression. And then ultrasound is the imaging of choice of patients who do have abnormal liver function testing, and a nodular pattern ultrasound does suggest cirrhosis. And there was a multi-center study, a PUSH study, that looked at ultrasound to predict hepatic cirrhosis, and they found that if they saw a heterogeneous pattern of the liver on ultrasound, that would predict progression of disease. More recently, elastography has been used, which to measure liver stiffness, and that may also be an important factor to help predict progression to severe disease. And in terms of treatment, the treatment options for CFLD are really limited. Ursodiol has been sort of the mainstay of treatment, and it's a natural bile acid that's thought to reduce periportal inflammation. But there have been several sort of observational studies in CF, and it doesn't seem to have much clinical utility to prevent progression. And in terms of modulator therapy, there's little known about the long-term impact or the development of a progression of CF disease, liver disease. But there are some smaller studies that have looked at hepatic steatosis and biliary dilation and CF in those who are on modulator therapy, and there does seem to show some improvement. And I think also important caveat to know is that these modulator therapies actually can cause elevated bilirubin and transaminase. So especially Trikafta, the recommendation is to get baseline liver functioning and monitor every 3 months. And so it's really important if you have known liver disease to then monitor very closely. And there are alternate sort of dosing strategies that have been tried for patients who do have transaminitis. And ultimately, for patients who progress to sort of end-stage disease, liver transplantation is sometimes indicated. So portal hypertension is one of the most serious consequence, and that basically develops because of increased revascular resistance and changes in splanchnic blood flow. And basically, really the esophageal varices can develop, which have a high risk of bleeding, which can lead to mortality. And there are also other syndrome like hepatopulmonary syndrome, which can cause dilation of the pulmonary capillary bed, and that can lead to right-to-left shunting and hypoxemia. and portopulmonary hypertension, which is pulmonary arterial hypertension that can lead to right heart failure. And then in terms of transplant, hepatic and extrahepatic manifestations should be taken into account. So if patients have deteriorating nutritional status or lung function related to liver disease, that may be an indication for transplant. And the development of variceal bleeding or hepatopulmonary or portopulmonary syndrome are also indications for transplant. So moving on to endocrine aspects of liver disease. So there are multiple endocrinopathies that are associated with liver disease, and some are a direct consequence of liver dysfunction. And there was a recent study looking at matched controls of patients with CFLD and without in patients with CF, and there was much higher rates of endocrinopathies in patients with CFLD. And those with CFLD are at risk for vitamin D deficiency, vitamin K deficiency, impaired glucose metabolism, hypogonadism, and bone disease. So vitamin D deficiency occurs on CF because of malabsorption, and in CFLD, the increased biliary stasis can exacerbate that, and additionally, patients may have impaired 25-hydroxylase activity because of cirrhosis. In addition to the vitamin D deficiency, vitamin K deficiency occurs for the same reason due to impaired absorption. Patients also can have hypogonadism. Present in cirrhosis. You can have hypogonadism just in CF in general, but with cirrhosis, it can be multifactorial due to suppression of the hypothalamic pituitary gonadal axis and elevated inflammatory cytokines, poor nutritional status, and altered hepatic metabolism of steroid hormones or impaired production of sex-binding hormones. And then finally, cystic fibrosis-related bone disease is much more common in patients with liver disease, and it's likely multifactorial due to the factors we just discussed, due to elevated inflammatory cytokines, low BMI, hypogonadism, vitamin D and vitamin K deficiency that are all seen with liver disease. So next, I'll move on to CFLD and CFRD and the overlap. So we all know that the liver is an important endocrine organ for gluconeogenesis and glycolysis, and impaired glucose tolerance and diabetes is much more common in those with liver disease, including cirrhosis. And those with CF liver disease is an independent risk factor for development of diabetes, with having a 2 times risk of developing diabetes in the setting of liver disease. And the pathogenesis of CFRD, and we talked about, is multifactorial, and we mentioned that it's due to the progressive beta cell dysfunction and destruction. But with CFLD, there's additional mechanisms that can actually cause hyperglycemia and actually increase insulin resistance. And hepatic diabetes refers to impaired glucose metabolism in patients underlying cirrhosis due to decreased insulin sensitivity and insulin resistance. So here is just a schema of how liver cirrhosis and liver disease can actually contribute to impaired glucose metabolism, and it's thought really to be underlying cause in increasing in liver disease insulin resistance. So you have combination of shunting and decreased hepatic clearance due to hepatic cell dysfunction, and that can lead to increased gluconeogenesis and increased glycolysis. And then in addition, you have many other hormonal abnormalities, including IGF-1, or increased growth hormone and growth hormone resistance, elevated levels of glucagon, which we've talked about, elevated levels of free fatty acids, and inflammatory cytokines, which can all affect the glucose metabolism. So, let's see, I'm running out of time here. So this is sort of the mechanism, a summary of the mechanism by which these different derangements can actually impair glucose metabolism by combination, basically increasing hepatic glucose production and decreasing peripheral insulin or glucose metabolism. So overall, I think effective treatment for CFLD right now is limited. And we really, right now, interventions are optimizing nutritional status and identifying comorbid conditions. And we, there are challenges to diagnosing and predicting the progression of disease. And really, I think the theme of the day is understanding really how Trikafta and highly effective modulator therapy is going to alter liver disease, its progression, or prevent its development in the first place. So I'd like to thank my co-authors on the paper, my mentors, everyone here, the foundation, and on some pictures of a grizzly I saw the other day. No, I didn't see that.